Hello, I'm Alison Cuellar. I'm a professor of health administration and policy at George Mason University and the chair of the Community Preventive Services Task Force. And I'm delighted to talk to you about the patient navigation to increase cancer screening and advance health equity, a recommendation of the CPSTF recently. To explain a little bit about the Community Preventive Services Task Force, it was created over 25 years ago. We're an independent, non-federal panel of 15 public health and prevention experts, both in practice and in the academic community. And we develop guidance on community-based interventions, public health intervention approaches that work based on the available scientific evidence. We have over 30 liaisons, one of which is the U.S. Preventive Services Task Force, as well as the Armed Forces, a number of federal agencies and non-federal agencies like the Association for State and Territorial Health Organizations, the American Academy of Pediatrics, America's Health Insurance Plans, and others. To explain the relationship between the US PSTF, which you may be familiar with, and the Community Preventive Services Task Force, I like to think of the US PSTF in simple terms as the entity that makes recommendations for clinicians at the clinical encounter in that face-to-face setting with the patient, whereas the CPSTF focuses on community-based interventions, which could be in healthcare systems, employers, public health departments, pharmacies, schools, and similar. And like the CPSTF, with slightly different methods, we conduct systematic reviews and make recommendations at the population health level. So I want to focus now on a recent recommendation related to patient navigation and cancer screening. We looked at three particular cancers: breast cancer, cervical cancer, and colorectal cancer screening. Just to set the stage for you, I want to talk a little bit about the cancer incidence rates for these three types of cancer and the death rates. As you can see, the top line is the overall rate, and below that, we show the rate by race and ethnicity. And while the incidence rates are relatively similar, you notice that the death rate for colorectal cancer is particularly high for Black men and women, and the rates for breast cancer and cervical cancer are particularly high for Black women. When we look at the screening rates, and each row here is a cancer type: breast cancer, cervical cancer, colorectal cancer. Over on the right, you'll see in red boxes the populations which have lower screening rates compared to others. So what stands out here are the low rates based on low income and the lack of insurance, particularly health insurance, as well as some racial and ethnic groups. These are groups, only one group meets the Healthy People 2030 cancer screening objectives, and that's the high income group. We set out, when we do a systematic review, to define the intervention of interest. And in this case, it was patient navigation services provided through healthcare systems to help patients overcome barriers to accessing cancer screening services. And these are services that are targeted to populations experiencing greater disparities in cancer screening, including those who are historically disadvantaged by race and ethnicity, and people with lower incomes. As we approach the literature, the patient navigation services had to include one or more of the following: client reminders, reducing structural barriers, which are things like assisting with appointments, translation, childcare, arranging alternative sites. Could also include reducing patients' out-of-pocket costs. It might also have included one-on-one or group education to inform patients and their understanding of cancer and cancer screening. And the services could be delivered by community health workers, nurses, patient navigators, social workers, or others. They were typically designed to be culturally and language appropriate in their local communities. So in our review, we were asking two questions. How effective were these patient navigation service interventions to increasing the cancer screening rates among people from historically disadvantaged racial and ethnic populations and people with lower incomes? And did that effectiveness vary with the population and the intervention characteristics? Now notice patient navigation can exist across the continuum. We here in this review, we're focused on screening. So conditional on screening, somebody might have been diagnosed with cancer and received navigation to treatment services. That's not the point in the continuum that this evidence review speaks to. That would be a separate set of evidence. We were focused on increasing screening rates through patient navigation. So here are the results. In the literature, there were 11 studies related to patient navigation in breast cancer, 3 related specifically to cervical cancer, and 27 to colorectal cancer. And the individuals were trying to increase screening across cancer types. They were all US-based. They were from different parts of the country. And you can see that while most were rural, there were several that were, and most were urban, there were several that were from rural areas as well. The types of services, some cases were only a community health worker or a patient navigator. In other cases, they had other elements. Some of them were remote only, and that may be of particular importance to rural areas, where a remote might be something like sending a kit for colorectal cancer screening, an FOBT or an FIT kit. And it might also be face-to-face or a combination. So when we looked into the studies and the specific interventions, what did they provide? Most were reducing administrative barriers, assisting with appointments, assisting with transportation, a few in childcare or offering alternative screening sites. In addition, many were including client reminders and potentially reducing patient out-of-pocket costs. And that most frequently was providing the return postage for the FOBT or FIT kits. Additionally, they might have been providing, many of them provided one-on-one education, small media, meaning flyers or videos. A small number were providing group education. And then there were other provider-oriented services, such as reminding the provider, alerting the provider to the fact that the individual is behind on their recommended screening. The population, the median age was close to 60. Most had less high school or less education. Most were publicly insured or not insured. Slightly more than half were female. And the majority had annual incomes of less than $40,000 per year. Of the studies that we examined in our review, there was an overrepresentation among Black and Hispanic populations. This chart shows you the national average in light blue and the population distribution in the studies we reviewed in dark blue. In addition to that, a third of the studies examined the patient navigation intervention in a single population, such as American Indian or Asian, Black or African American or Hispanic Latino. So what did we find in terms of the overall results? What's exciting, I think, about this evidence review is that we find patient navigation increased cancer screening across the 3 cancer types. It increased breast cancer screening by 12 percentage points. It increased cervical cancer screening via Pap test by 22 percentage points, and increased colorectal cancer screening, regardless of whether it was by colonoscopy or FOBT or FIT kit. On this slide, what you'll see is the blue bar is the before intervention screening rate, and the green bar is the after intervention screening rate. The horizontal line is the Healthy People 2030 goal. So while these screening rates increased considerably, they don't get us quite to the Healthy People 2030 goals. And I think it's important to understand that the patients in these studies faced multiple barriers to accessing care, but that patient navigation may play an important role in at least improving those screening rates. When we dug into the interventions and tried to understand where it might be more effective, we found that these patient navigation interventions, it didn't really matter where in the US they were implemented. We found greater increases in rural areas than in urban areas. We didn't find differences whether it was clinic only, or clinic and community-based approaches within the healthcare system, or even whether it was remote only or remote and face-to-face. Similarly, the number of services did not seem to be predictive of the increase in the screening that was achieved. We did find, though, that there was a greater increase in the screening if the navigator or the community health worker was working within a team as opposed to on their own. So our finding statement is that we, as a Community Preventive Services Task Force, recommend patient navigation services to increase breast, cervical, and colorectal cancer screening among historically disadvantaged racial and ethnic populations and people with lower incomes. And by extension, those services are expected to advance health equity when implemented among these populations because they often have lower screening rates. Important part of the work we do, in our view, is to help uncover evidence gaps. So here are some things where we feel like we need more information. What is the impact on navigation for repeat screenings? This was predominantly a population that was behind on their screen. What about the follow-up diagnostic tests for patients with positive screening results? We didn't have a lot of evidence on cervical cancer screening for younger females or for colorectal cancer screening for adults aged 45 to 49, or using some of the other USPSTF recommended tests. And we don't know if the intervention effectiveness varies by the patient's health literacy or by the number of contacts between those service deliverers and the patients. All of the information from the CPSDF is captured in what I think is a marvelous website called thecommunityguide, all one word, .org. The communityguide.org has the full, as we call it, TIFRs, the task force recommendation, with a rich set of implementation considerations for the setting, for the rurality, whether the hospital system, the type of team that is formed. A number of considerations are in there that we've gleaned from the literature, as well as one-pagers and other materials, including even sites where these patient navigation services have been implemented as examples. I highly recommend the website to you. And that is the summary of the patient navigation recommendation from the CPSTF. Thank you.